My name's Adam Burnett, and I'm the Digital Marketing Manager here at Rainmaker Strategic Solutions. Today, I'm talking with Dr. Adrienne Mims, who is the Chief Medical Officer here at Rainmakers, around an exciting topic of health equity and value-based reimbursement systems. Why adopt a pay-for-performance system?
In a pay for performance system, the insurer, whether it's Medicare, Medicaid, private insurers, would be saying that I want this level of performance from the care that you give. Not that I want you to see my patients when they have high blood pressure. I want to ensure that the vast majority of them, their blood pressure is controlled. I want to ensure that their diabetes is under control. I want to ensure that they have um, um, low hospitalization rates. I want to ensure that they're making the best use of long term care without excessive use of those services. So, in a pay for performance system, we have the ability to pay up front for care for the year for a population of patients. And by doing that, it allows one to redesign the system of care. A good example of that is joint replacement. Joint replacements, like hip and knee replacements, are some of the more common surgeries that occur in America. And as our population ages, it will become even more common. Not quite as common as cataract surgeries, but pretty much up there. I can recall 10, 15 years ago when my mother had her hips replaced and she was in her late 60s. She was in the hospital for a week and then afterwards went to rehab. What we look at is that if we're just paying for the procedure, the surgeon gets paid, anesthesia gets paid, the hospital gets paid, long-term care gets paid. But what the government, CMS, realizes that sometimes we are not maximizing the best outcomes. And so if we pay for performance and have an upfront payment for joint procedures, we then can ensure that the money is being used most effectively. What has happened as a result is that many of those procedures have changed to same day outpatient procedures where people are screened in advance to make sure that they are healthy enough to undergo such a procedure. Therefore, in these elective procedures, those whose blood pressure or weight or diabetes or heart condition or pulmonary condition and lung condition were not optimized, they were then sent back to primary care for that to be done. Because those hospitalizations and long term care bills that occurred afterwards were primarily because those patients' systems were not optimized prior to surgery. As a result, we've cut significant costs out of joint replacements. And that can happen across our healthcare system when we look at value based payment, when we're looking at what is the whole package of need for that individual. So instead, not only are patients optimized prior to surgery, they go through education and learn about physical therapy and are strengthened prior to the surgery. And since their medical conditions are optimized, they don't have long hospitalizations afterwards or have less side effects that need or complications that need rehabilitation afterwards. And I think that as we begin to look at these value based payment systems, we are now incentivizing the delivery system to look at the patients more holistically in designing their care. So if a patient has, if I am as a healthcare system paying for a population I know has diabetes, COPD, and heart disease, and I'm paying upfront for that population's care, as a healthcare system, I can ensure that I'm providing easy access to care, I'm providing patient education, I'm providing optimal medication, I'm providing nutritional services, I'm providing exercise and other things that would be important rather than if I'm in a fee-for-service environment and the person's just coming in and I'm making recommendations and making referrals and writing medications. It shifts the paradigm of care.